Dear students, in this clinical snippet, we will be discussing about ptosis. Ptosis in various scenarios. If we see ptosis, that is drooping of the eyelids, it can be unilateral or bilateral. Depending on the situation, if there is a drooping of eyelid or ptosis, what clinical scenarios would be there after clinical examination? So let us start one by one as a differential approach to ptosis. So पहला सिनेरियो देखते हैं कि there is a ptosis. You see that the eyelid is drooped, complete drooping of eyelid. Complete drooping of eyelid. Now you elevate the eyelid. The examiner elevates the eyelid. Completely drooped, elevates the eyelid. Scenario 1. What did we see? We saw that the eyeball has been positioned down and out, and there is mydriasis. So position of the eyeball is down and out, and there is mydriasis. So this will confirm third nerve palsy. So third nerve palsy or oculomotor nerve palsy. If there is a unilateral third nerve palsy, you will get this sign. Bilateral third nerve palsy scenario is different. We will talk later on. But ptosis scenario number 1, these are the clinical feature: mydriasis, down and out, third nerve palsy. Second scenario, there was ptosis but not complete ptosis, drooping of the eyelid present, and if the patient is asked to try to compensate, try to elevate the eyelid, there is some amount of power is there. The patient is trying his best to elevate, but still plus minus getting elevated or not. There is compensatory wrinkling on the forehead. समझ लो there is a ptosis, partial ptosis, not complete. Ask the patient to lift the eyeball as per his own efforts. The patient tries, and there is a little bit improvement with compensatory wrinkling on the ipsilateral forehead. The patient is trying his best, and there is slight improvement. And again, you personally also elevate, the examiner elevates the eyelid. What did he see? He saw nothing normal, but the pupil is myotic pupil. Myotic pupil. So the diagnosis will be Horner syndrome. So second scenario, उठाया, myosis देखा, Horner syndrome सोचना पड़ेगा. Additional features you have to search for: anhidrosis, enophthalmos. Palpebral fissure is narrowed already. Okay. And lastly, ciliospinal reflex. Test for the ciliospinal reflex. Pinch the ipsilateral side neck, skin of the neck. You have to pinch and see whether there is pupillary dilatation. Here, there is no pupillary dilatation. So ciliospinal reflex is absent. Here it was scenario 1, it was parasympathetic paralysis, parasympathetic palsy. Horner syndrome is due to sympathetic palsy. That's why myosis, that's why mydriasis. So two scenarios, ptosis. Next scenario, patient with ptosis may be unilateral, may be bilateral. May be bilateral, may be unilateral ptosis. Again here, the clinical scenario is little bit like the earlier Horner syndrome type. But here the clinical history is important. The patient is saying that this ptosis is fluctuating. Is this ptosis fluctuating? Is this episodic? If these history are present, episodic fluctuating ptosis with fatigue, these classical pearls in history. So it is not a continuous ptosis. In the morning hours, everything is fine. But in the evening hours, there is a development of ptosis, usually asymmetrical. Later on, it can be bilaterally symmetrical. If this episodic, fatigable, fluctuating ptosis is present, then we have to think of myasthenia gravis. So ophthalmic involvement in myasthenia gravis, it starts like this only. Ptosis, ophthalmoplegia. So ptosis is the earlier sign. And when we talk of ptosis, we are talking of levator muscle, levator palpebrae superioris. Till now, barring one conditions, whatever scenario number one, it was levator palpebrae superioris weakness. Scenario number two, Horner syndrome, it is mainly the Muller's muscle, which is another elevator of the eyelid. Sympathetic innervation paralysis. Here also again levator palpebrae superioris muscle is weak because of myasthenia gravis, neuromuscular junction disorders. So as I say, fluctuating, episodic, fatigable ptosis, myasthenia gravis is suspected. Say the patient is presenting with unilateral ptosis and you are suspecting myasthenia gravis with this clinical scenario in history. What we do? What can we do? Bedside, what can I do? See, first I will see for if say there is a asymmetrical ptosis, unilateral, this eyelid is drooped down, levator weakness, this is the normal eye. What I will do is I will do a test. That is, I will try to elevate the eyelid. The examiner will elevate the eyelids of the ptotic eye. And when I am elevating this, there will be ptosis of the normal eye. When I am elevating the ptotic eye, the other eye will lead to ptosis. This is a positive Curtin's test. Curtin sign. Second, what I can do is I will apply a ice pack test. If you apply the ice pack on the ptotic eye, the ptosis will improve. Ptosis will improve. Again, confirmatory test for myasthenic ptosis. Because ice pack temporarily inhibits the cholinesterase enzyme. So when the cholinesterase enzyme is inhibited, there is increased acetylcholine in the post-junctional membrane, neuromuscular junction, improvement of ptosis. Third, what I can do, I can trigger fatigue because it is a fatigable weakness. It is a fatigable weakness. So I will trigger the fatigue. How? I will ask the patient to look up, continuously look up. Look up like this. So the ptotic eye will become more aggravation of the ptosis and the other eye there may be ptosis because of continuous exercise. So fatigable ptosis can be demonstrated by this. Lastly, I can do a test which is known as edrophonium test. Acetylcholinesterase inhibitors, edrophonium, or give a tablet of neostigmine or pyridostigmine tablet pyridostigmine. Ptosis will improve. It's myasthenic ptosis. Next scenario, myopathies. So here there is unilateral or usually bilateral ptosis. Bilateral ptosis. And we have to think of whether it is a myopathy. Earlier was a myoneural junction disease. Now, myopathies, that is the primary muscular disorders, weakness of the primary muscles, and they are also involving the levator palpebrae superioris muscle and causing bilateral ptosis. So, what are the myopathies that can be causing ptosis? There are congenital myopathies. Congenital myopathies. Like Nimanil myopathy, central core myopathies. Okay, so congenital myopathies. Myotonia dystrophica. Myotonia dystrophica. Oculopharyngeal myopathy. Facioscapulohumeral myotonic dystrophy. Facioscapulohumeral dystrophy. So facial muscle, periscapular muscle, proximal muscle, ocular muscle, classical ptosis, and pharyngeal weakness, bulbar weakness. Myotonic dystrophy, classical features, there is frontal baldness, loss of hair, snarling type of face, झूला हुआ चेहरा, bilateral facial muscle weakness, ptosis due to levator weakness. It's like this, something like this. झूल गया है चेहरा, ptosis. Ask the patient to look up, head tilt, compensatory wrinkling of the forehead, and patient can look like this because he is trying to look to avoid the ptosis like this. Head tilt, head tilt. So these are important clinical clues. Myopathic faces, proximal weakness. So there will be drooping of eyelid. So it's myogenic cause or myopathic cause you have to rule out. So congenital myopathies, myotonic dystrophy, oculopharyngeal, facioscapulohumeral, some mitochondrial myopathies, mitochondrial myopathies, chronic progressive external ophthalmoplegia. So these are all myopathic condition. Want to go for muscle biopsy, CPK levels, and genetic testing. All these things can be done to diagnose myopathic ptosis. Sudden onset. Yes, sudden onset. Conscious patient. Conscious patient. Ask history. Snake bite? Yes. Neuroparalytic snake bites. Neuroparalytic snake bites. Great. Cobra. So very important. Why? Because these are the persons, those will develop now diaphragmatic weakness, respiratory paralysis, neurotoxic snake bite, bilateral ptosis, initial presentation, history of snake bite, and patient is developing ptosis. Immediately go for diaphragmatic test for breathing, breath count tests, arrange ventilator, monitor, start treatment immediately, ASV, again, neostigmine, pyridostigmine. So clinical feature is like myasthenia ptosis, like myasthenia. Because again neuromuscular junction, alpha bungarotoxin, it can involve presynaptic level or postsynaptic level. So these are the acetylcholine receptors, nicotinic acetylcholine receptors, presynaptic vesicles. These vesicles contain acetylcholine, calcium channel. So here, in a case of a great bite, it is presynaptic blockade of vesicle release. Presynaptic blockade of vesicle release in crate. So acetylcholine is not getting released, weakness, ptosis, respiratory paralysis, body paralysis. Now in case of cobra, it's like myasthenia, replacement of the acetylcholine receptors by bungarotoxin. Here it is a postsynaptic defect, replacement of the acetylcholine receptors by bungarotoxin. Here acetylcholine is coming into the synaptic cleft, but there are no receptors, so no action potential. No action potential, weakness, ptosis, snake bite, history, ASB, immediate management. Last scenario, let us see. Sudden onset, yes. Consciousness, no. Or stupor, disorientation, stupor, coma, semi-coma, bilateral ptosis, catastrophe, bilateral ptosis. Quadriplegia, quadriplegia is present. Bilateral long tract signs, plantar extensor. Plantars are bilateral extensor. Okay. So plantars are bilateral extensor, bilateral long tract signs. Decerebrate posturing, decerebrate rigidity, bilateral ptosis. So in this scenario, we have to urgently rule out midbrain stroke. So maybe it is a tip of basilar syndrome. Bilateral P1 segment. These are the posterior cerebral artery, vertebral artery, basilar artery, posterior cerebral artery, and here there is a block, thrombus, acute onset stupor, with or without preservation or loss of consciousness. Bilateral extensive midbrain damage. Bilateral extensive midbrain damage. Bilateral P1 गया क्योंकि tip of basilar syndrome. So extensive midbrain damage, and we know the oculomotor nucleus is present in the midbrain. So bilateral oculomotor paralysis, third nerve paralysis, ptosis. If sometimes the consciousness is preserved, sometimes the consciousness is preserved, that means the reticular formation is spared. Sometimes the reticular formation is spared and the consciousness is preserved, and the tip of bacillary syndrome presents like a locked in syndrome. Locked in state, complete quadriparesis, complete lower cranial paralysis, only there is a vertical eye movement present, ptosis, nothing else. And if the consciousness is impaired, then it can be involvement of reticular activating system. Only thing is we have to rule out catastrophic stroke like a midbrain syndrome, bilateral midbrain syndrome due to a acute onset stroke, tip of bacillary syndrome. So to summarize, we have discussed ptosis, unilateral ptosis disorders, third nerve palsy, Horner syndrome, then myopathic ptosis, myasthenia gravis, fatigable, episodic ptosis, snake bite should be ruled out, bilateral ptosis, and lastly, with coma or with catastrophic presentation, sudden onset ptosis can be ruled out by urgently detecting the clinical sign of comatose patient, dysregulated posturing, granular weakness, bilateral contracture extensor. It can be extensive stroke involving the midbrain, bilateral midbrain. Thank you.